Production. Let's get it.
Hello, it's me, Dr. Butler. As we close out Women's Heart Health Month, I want to shine a light on an issue that often gets overlooked: the cultural and racial disparities that shape women's cardiovascular health. In the United States, cardiovascular disease remains the leading cause of death for most racial and ethnic groups, yet the burden is far from equal. Data from the American Heart Association and the CDC through 2026 reveals a striking difference in the prevalence, risk factors, and mortality. In women's health, a one size fits all approach to cardiovascular disease misses the mark, especially for women of color who face unique and often compounded risks. While heart disease is the number one killer of women overall, recent data makes it clear that the danger is not distributed evenly. Unfortunately, Black women experience the highest burden of cardiovascular disease in the U.S. 59% of Black women ages 20 and over are living with some form of cardiovascular disease. Cultural and racial disparities in cardiovascular health don't arise from biology alone. They are a result of a complex mix of structural inequalities, lived experiences, and systematic barriers that shape how women of color access care, experience stress, and navigate health systems. Women of color, especially Black, Latina, and Indigenous women, experience higher levels of chronic stress due to structural racism, discrimination in healthcare, workplaces, and daily life, caregiving burdens, and economic instability. The chronic stress activates the stress response, which increases inflammation, blood pressure, and metabolic dysfunction, key contributors to hypertension in the world. Roughly 59% of Black women have high blood pressure or hypertension because of stressors I just mentioned. Only 25% of these women effectively have it under control. Black women have a greater sodium sensitivity, meaning smaller amounts of sodium causes increase in blood pressure. The kidneys retain sodium more easily, and blood vessels respond more strongly to sodium-related volume changes. This sensitivity becomes even more pronounced during the menopausal stages when estrogen declines and vascular stiffness increases. Beyond biology, social determinants, including restricted access to healthy foods and safe parks, along higher exposure to pollutants and economic instability, act as a catalyst, elevating blood pressure over a lifetime for women of color. The national data shows that Black adults have higher hypertension but lower control rates than white adults. This results of disparity in healthcare access and treatment. Black women often face delayed diagnosis, undertreatment, lower rates of blood pressure medication use, and distrust of the healthcare due to historical and ongoing discrimination. The American Heart Association reports lower rates of medication use among Black adults, partly due to access barriers such as medical mistrust. Historically, the health needs of women of color have not received the attention they deserve. Black women often enter perimenopause earlier with more pre-existing risk factors. These changes increases the risk of hypertension in midlife. To understand why cardiovascular disparities persist among women, it is necessary to look beyond the traditional risk factors like diet and exercise. The problem is rooted in the complex intersection of social environments, cultural expectation, and systematic failures in healthcare. The American Heart Association recognizes that language barriers, cultural stress and beliefs about illnesses, and mistrust of the healthcare system disproportionately affect women from underrepresented racial and ethnic groups. Heart disease is still culturally coded as a male problem, even though we know heart disease is the number one killer of women. A study found that young women associate heart issues only with older men, leading them to dismiss their own symptoms like fatigue or indigestion as temporary stress or just being tired. In some communities, a historical distrust of medical system due to past unethical experimentation or current discrimination leads women to delay seeking care until a cardiovascular event has already been in progress. For example, James Marion Sims, who is widely referred to as the father of modern gynecology, but his legacy is deeply controversial due to the unethical experiments on enslaved black women without anesthesia. The most well known women were Anarcha, Betsy, and Lucy. How about something more recent? In 1951, Henrietta Lacks, a 31-year-old black mother of five, was treated for cervical cancer at Johns Hopkins Hospital in Baltimore, but her family didn't find out until the 1970s. During her treatment, a doctor took samples of her tumor cells without her knowledge or her consent. Her cells have been used in the development of polio vaccine, cancer, AIDS, leukemia, Parkinson's disease, even COVID-19 research. In 2023, her family reached a historical settlement with the biotech giant Thermo Fisher Scientific regarding the stolen cells, and they continue to pursue ongoing legal action. As we confront the cultural and racial disparities that shape women's cardiovascular health, it becomes clear that the real change requires more awareness. It requires empowerment, community partnership, and system level transformation. Empowerment begins with education, giving us the knowledge to recognize symptoms, understand our risks, and advocate for ourselves in medical settings. But education alone is not enough. Environments must be created where we feel seen, heard, and supported. This means there must be an expansion of culturally responsive care, increased representation in healthcare professions, and training for clinicians to understand the lived experience of women of color. Community-based solutions are equally essential. When health initiatives are rooted in the community, whether through churches, barbershops, sororities, neighborhood centers, or local organizations, they become more accessible, more trusted, and more effective. Peer-led support groups, community health ambassadors, and partnerships between academic institutions and local leaders have all been shown to improve cardiovascular outcomes. These models work because they honor culture, they build trust, and they meet us women where we are. And finally, empowerment requires systematic changes. We must advocate for policies that expand access to care, improve food environments, fund safe spaces for physical activity, and ensure that women of color are represented in clinical research. When system shifts, outcome shifts. Women's heart health is not just a medical issue, it's a social, cultural, and structural one. And while disparities are real, so is our power to change them. We must combine science with community. When we honor culture along clinical care, and when we empower women with knowledge and support, we create a future where cardiovascular health is not determined by race, zip code, or circumstance. Every woman deserves a chance to live a long, healthy, vibrant life. Together, we can make this a reality, one community, one conversation, one empowered woman at a time. Thank you for watching. And next month, we will be focusing on balancing our lives with imbalanced hormones. Don't forget to comment, like, and share this video.